Okay, well, hello everyone, welcome, and thank you for joining our one-year anniversary of Gateway College Lecture Series. We greatly appreciate your support and interest in contributing to the knowledge economy. My name is Gwen Devereaux, and I'm the president of the Board of Directors of the Center of Excellence in Rural Health. And Gateway is located in Goderich, Ontario, and to our knowledge is the only rural health research center in Canada governed by a community-based volunteer group. We are partnered with several academic centers and healthcare facilities, and Gateway's aim is to advance rural health teaching and research across Huron, Perth, Grey, and Bruce. Our mission is simply to improve the health and quality of life of rural residents through research, education, and communication. Beginning in February 2021, Gateway launched its first virtual lecture series, with social isolation being at the top of mind as COVID-19 restrictions continued to heighten. There was no better time to launch this initiative. Through this lecture series, our hope is to promote a culture of rural health knowledge and innovation, while virtually connecting communities to reduce social isolation. Today's speaker is Dr. Craig Hudson, and Dr. Hudson is a psychiatrist and Gateway's chair of rural mental health. He is speaking today on pumpkin seeds from Southwestern Ontario and implications on sleep, a very intriguing topic, so we're all excited to hear this. Throughout his career, Dr. Hudson has maintained an interest and a balance between lab-based research and clinical work. Some recent topics of research exploration include natural source tryptophan, essential fatty acids, movement disorder, and cognitive impairment treatment. He has published extensively in a variety of medical journals, including Archives of General Psychiatry, British Journal of Psychiatry, Canadian Journal of Physiology and Pharmacology, Nutritional Neuroscience, Parkinson's Disease, and Journal of Affective Disorders. Dr. Hudson has authored several books and holds 26 patents. And if that's not enough, he is past recipient of a Medical Research Council Clinician Scientist Award, and he has extensive clinical and psychopharmacology experience and maintains both an outpatient and hospital-based practice. Our panelists today are Lynn Harris and Patricia Robinson. Lynn is a recently retired social worker who worked in Huron and Perth counties for over 30 years. The bulk of her work has been mental health. She's dabbled in domestic violence, affordable housing, community mental health, employment counseling, and community legal work, including social justice issues. Her most recent work was with the Maitland Valley Family Health Team for the past 15 years, where she has been involved in implementing the mental health programs there, providing counseling and support services, as well as collaborating on the creation of various programs in primary care. For many years, she ran a program for insomnia using behavioral and cognitive strategies to address impaired sleep. And I like that, Lynn, in impaired sleep. Patricia is a nurse practitioner at the Maitland Valley Family Health Team, and where she's providing primary care for over 700 patients. She also is the clinical lead of the COVID response and a team member of the memory clinic there. While Patricia enjoys outdoor sports such as skiing, hiking, horseshoes, cross country, and kayaking, she also has shared that she enjoys a good night's sleep. So she will be sharing some of her observations on sleep patterns in patients as we all are journeying through this pandemic. Thank you so much for joining us, all of you, and I will pass this over to Dr. Hudson to begin the discussion.
Thank you, Gwen. So I'll just kind of talk about how I came to look at tryptophan in the pumpkin seeds from Southwestern Ontario, but just to kind of tease everybody a little bit, pumpkin seeds from Southwestern Ontario are the highest natural source of tryptophan known to man. about 22 milligrams of tryptophan per 1 gram of pumpkin seed protein. So a very high amount. But let's talk about how I came to find that out. So in the 1990s, 1980s and 90s, I was a medical student and a resident in Toronto and started off in medical school there and a residency in psychiatry. And I was interested in subtyping people with schizophrenia, not by clinical phenomenology, but rather by the way one cell talked to another cell. So if I could find some common problem between the ways the cells communicated, I could find a subtype of schizophrenia, a phenotype, if you will, so I could do further genetic studies. That was my theory at the time. I came to realize that the prostaglandin receptors were downregulated. Prostaglandins are the one messengers inside of our body. And I was able to induce the prostaglandins to circulate in the blood by giving people niacin, vitamin B3, basically. And when I did that, I developed a technique of measuring the blood flow and measuring that in people. I found about 40% of people with schizophrenia do not flush or do not generate a facial flush when taking niacin. A large amount of research of why that's the case. And indeed, that follows this kind of phenotypic process where the more people in your family that don't flush when taking high doses of vitamin B3 also heightens your risk of schizophrenia. So the more non-flushers within the family identified people at risk for schizophrenia. I worked with some people at Sick Children's Hospital at that time to find a genetic component to identify genetically what was going on at that time. And I published all of that. But it was a time of great, kind of a tumultuous time in Toronto. The hospitals were restructuring, where about 50% of the psychiatric beds would be lost in a few years. The lab base that I was working at was shifting. And indeed, the company that had been funding the research was under some economic frustrations as well. Long story short, I moved to Stratford at that time to have kind of a quieter time in a rural hospital as I worked out psychiatry, but had a view of wanting to continue my work in molecular genetics, which I did. But in order to make that happen, I realized I would need to sell or do something to generate revenue so that I could continue the research. So when I thought about it, I thought about tryptophan. Tryptophan is an essential amino acid. It means your body's not going to produce it, you have to eat it. When tryptophan gets into the brain, it undergoes 2 steps, hydroxylation, decarboxylation, and it becomes serotonin. In the dark, and only in the dark, it undergoes 2 more metabolic steps, methylation, and then carboxyl groups attached, and it becomes melatonin. So tryptophan becomes serotonin in high light conditions. It becomes melatonin in dark conditions. And as soon as your retina sees light, it's back to being serotonin. So it's a treatment for anxiety and so to some degree depression and insomnia. So throughout the 1980s, it was available synthetically in the United States. And at one point, 2% of the American population was taking tryptophan every day. So that would be the equivalent of 36,000 kilograms of tryptophan required every day to meet the US demand. A company in Japan, the Showa company, decided to genetically modify a bacterium to grow tryptophan rather than produce it synthetically. And that was the very first genetic engineering experiment. They imported this or exported their tryptophan from Japan into the US. And people started getting sick and some died from an autoimmune disorder, EMS, eosinophilia myalgia syndrome. The CDC and the FDA quickly traced back to this batch in Japan saying, what happened here? We're having a lot of sick people. We need to understand what's happening with your tryptophan. At that point, the company declined to participate in the investigation. And so the US took the position, if they didn't understand what was going on, they were going to shut down the sale and distribution of tryptophan totally across the entire country, which they did. So in 1989, tryptophan became a banned substance in the US, banned over the counter in Canada, and banned in totally in Western Europe, including England. So just an interesting drug that had a lot of advantages, which was suddenly taken off the market. It was available via prescription only in Canada, so I got a chance to keep using it. But I was curious, could I develop a product that utilize natural source tryptophan. If synthetic wasn't available, was it possible to find a natural source? We know tryptophan is in milk and turkey and cheese, we all know that. But I set about at the Guelph Food Technology Center to set up a second derivative spectroscopy study that allowed me to identify that tryptophan from pumpkin seeds was available in high amounts. And I can talk about why that was the case, but that's what I did. And I found, just what I told you before, 22 milligrams of tryptophan for every 1 gram of pumpkin seed protein. So I took the pumpkin seeds from Strathroy. I brought them back from Stratford. We harvested the seeds from the pumpkins, and then we sent it off for crushing, because when you take out the oil, you double the concentration of tryptophan, in the de-oiled seed meal. So now we have an enormously high amount of tryptophan. But if you eat just de-oiled seed meal, de-oiled pumpkin seed meal, paradoxically, the tryptophan levels in your brain fall down. That doesn't go up because of something called the tryptophan paradox. And this had always been the thing that had prevented people from using natural source of tryptophan, is that there are other amino acids bound to the protein bundle that have a higher affinity for the transporters to go across the blood-brain barrier. So if you eat pumpkin seed meal, very rich in tryptophan, your blood levels go up, but so do the levels of all the other competing amino acids, leucine, isoleucine, phenylalanine, and those other amino acids occupy the transporter. So even though the blood levels of tryptophan go up, the brain levels paradoxically go down. And so I thought of the way of adding a bit of dextrose. Dextrose turns on insulin, and insulin shunts away all the other competing amino acids, allowing tryptophan to access the blood-brain barriers, transporters, and then get into the brain. So we did this fairly large study in Stratford at the time, where we took de-oiled pumpkin seed meal combined with dextrose, and we took synthetic tryptophan with dextrose, and then finally we had dextrose alone in this 3-arm trial. And we sent people into try one of the 3 arms, so 3 options. And then we also sent them into a sleep school at the outset, where they learned cognitive behavioral techniques to help them with their insomnia. So the idea was either they would get this, what would be the new product, or they would get the drug, or they would at least get some measure of treatment with the cognitive behavioral treatment. And we discovered that cognitive behavioral treatment, as we had expected, helps people with chronic insomnia. We also discovered, not unexpectedly, that the tryptophan, the synthetic tryptophan, helps people with insomnia. We knew that already. But we found that the tryptophan from the pumpkin seed meal, when combined with the dextrose, was the most effective treatment of all 3 arms of the study. So we filed patents and published the study, and published follow-along studies over time. And now, obviously, as a physician in the province of Ontario, I can't talk about what happened next commercially, but it was interesting, and things kind of developed along those lines. And there are a number of advantages to using natural sources of this kind of approach to insomnia. The issues with traditional hypnotics, and we call medications that are used to treat insomnia hypnotics. The problem with hypnotics over, if you're using something like Ativan or Lorazepam, just any one in numbers, diazepam, Valium, any of those things, when you give those to people, they do fall asleep and they remain asleep. The problem is that they don't have the same sleep architecture. When you're using a benzodiazepine, you tend to lose some of the sleep architecture, especially the REM sleep and the slow wave sleep that tends to be dissipated. And you also get problems with tolerance and dependence. So you get accustomed to the medication over time, and you get not addicted to it, but hooked on it. So if you stop it, your problems become worse again. So even as you become tolerant, you become, the medication doesn't work as well, but if you stop it, then you're worse off than you were in the first place. So it's a medication that once you start down that process, you're kind of giving to people consistently, or you've got to find a way to back out of it. And that can sometimes be problematic. There are obviously other hypnotics used more recently with some success. There's some good success if you use it for short periods of time. I'm not an advocate of using those benzodiazepines for longer, or non-benzodiazepines for a longer period of time, because there are other associated with health concerns. Particularly, there was a series of fairly large studies in the British Medical Journal by Dr. Kripke from La Jolla, California, who at the Scripps Institute, who looked at, okay, what happens to people who take hypnotics consistently? Not necessarily benzodiazepines, but some of the newer hypnotics. And he looked at 10,000 people, and for every person in the study, he had 2 separate controls. So 10,000 people, 20,000 controls, so a large study. And it showed that there are health issues that arise from consistent use of hypnotics. I don't want to alarm anybody. I'm not going to get into that part. But if you have an interest, I would recommend you look at the BMJ, February 2012, and just to follow along with Dr. Kripke, as he kind of advocates for the alternate use of other medications or other natural treatments for insomnia. And so that's really what I have to say in a pumpkin seed shell. It's important, though, that there are other aspects that I just want to cover about tryptophan, because tryptophan now, of course, is available again after an extensive period of time off the market in the US. It was brought back, and it's available in the US as an over-the-counter item. It's also available now as an over-the-counter item in Canada, which it wasn't before. And it was available, or now is available in the UK and parts of Western Europe. Not all parts of Western Europe, but most parts of Western Europe will allow it. If you're using tryptophan, a synthetic source, it's very different than using the natural source of tryptophan I've just kind of described. And the natural source of tryptophan, it comes in nuts and things of that nature that have within it the things you need to keep tryptophan as it makes those 2 jumps from tryptophan to serotonin, and then from serotonin to melatonin in the dark. You need a B3 and B6. It needs to be somewhat contained in a kind of a bulletproof capsule, or the natural long-acting capsule of nature, of course, is the polypeptide chain. Tryptophan, when it's given synthetically, tends to come on quickly and off quickly. That half-life is about 1 hour. So if you're going to use synthetic tryptophan, I'm not discouraging it, but if you were to use that, you would have to remember to take it with a carbohydrate every day. You'd have to find a way to do that, or otherwise it's not going to access the brain. You should be taking a multivitamin every day that has vitamin B3 and B6 in it. Otherwise, the tryptophan that you're ingesting will become vitamin B3. So tryptophan will become vitamin B3 if you're under stress and you have depleted your amounts of vitamin B3. If you have a bit of vitamin B3 every day, that enzyme that allows the conversion from tryptophan to niacin, vitamin B3 is shut down. So tryptophan pyrrolase is shut down. So if you're taking synthetic tryptophan, very important to take a multivitamin with the carbohydrate. If you're taking the natural sources of tryptophan, you won't need to do that, because the B3 and B6 is kind of built into the natural constituents of the seed or the yogurt or the cheese or whatever you might have. If tryptophan is there, you're going to find naturally high levels of vitamins. So that's what you can expect if you're looking to try the pumpkin seeds from Southwestern Ontario. It is not like a drug like Ativan or diazepam, which will knock you out. It won't do that, but it will help you to utilize other techniques such as cognitive behavioral therapy techniques to achieve a better sleep. So you'll expect to reduce your time awake in the middle of the night with just about 30, 35, 40%, which is, again, it's not the be all end all, but it is significant. And if you can work with that number and using cognitive behavioral approaches, it can be a nice, effective treatment for chronic insomnia. The advantage of it, of course, is that it has preserved sleep architecture. Preserved sleep architecture means you're going to get all 5 stages of sleep. You're going to get stages 1 and 2, which is light sleep. You're going to get stages 3 and 4, which is a slow wave or deeper sleep. And of course, you're going to get REM sleep. And so when you're first taking the tryptophan natural source or synthetic, what you will notice is that your dreams will become very you'll become very aware of your dreams again. It is not necessarily a bad thing. It just means that your sleep architecture is recovering and you're now having a reemergence of your REM sleep. So I'm a big fan of the pumpkin seeds from Southwestern Ontario. I'm a big fan of pumpkin seeds in general. I can't say much more than that just because of the restrictions of what I can and cannot say. But I do recommend that you have a careful look at the literature. And I do recommend that if you're considering treating insomnia, that you incorporate a holistic approach, including cognitive behavioral techniques, including, having a dark room and that. I don't want to touch on those parts. I think some of our panelists will be able to kind of do a much better job than I will. So I'm going to stop at this point and let the panelists roll in with their thoughts on how to treat insomnia and maybe whatever critique they have of my talk. Thank you.
Great. Well, thanks, Dr. Hudson. I guess I can talk a little bit about some of the information that I have on improving sleep. And as Dr. Hudson said, improving your sleep is not sort of a one-stop shopping thing. In my experience, it takes a number of different modalities, and sometimes it's trial and error. Some things might work for some people that don't work for others. The program that I used to run at the family health team in Goderich incorporated one of the main things we would get people to do was to understand where they are having issues with their sleep, where their sleep is impaired. So a lot of people come in and it's just, I can't sleep, every night is bad, I don't know what to do. So it's kind of understanding where can I make improvements in my sleep? And then when you have a better understanding of that, then you can incorporate some of the techniques that people would learn in the program. So I became interested in sleep as a social worker because a lot of the patients I was seeing, many of whom would have meet the diagnostic criteria for mental health issues, mainly like depression and anxiety. Those are the two most common mental health issues that I would be seeing patients for. And almost all the time, people suffering from those conditions also had a lot of issues with their sleep. And they found, and what they found was that when they would get some improvement to sleep, that also then resulted in improvement in their symptoms of depression or their symptoms of anxiety. So most of the time, impaired sleep for long periods of time is triggered by an acute stress. So that's things like a death in the family, stress in the family, job stress, relationship stress, you name it, any of that can then result in people having impaired sleep. And then sometimes what happens is even though that acute stress gets resolved, or over time things improve, people then often find that they continue to have problems with their sleep. And so what I found was in order to get good sleep, people often will do anything to try to get it. So things like napping, going to bed early, taking, over-the-counter medication or prescription medication. And sometimes the behavioral end of things, sometimes those behaviors that you adapt when you're having poor sleep actually end up making your sleep habits more unhealthy. Things like, I'll use napping as an example, or going to bed early. So sometimes actually going to bed early is probably a better example. So if you've had a really poor sleep and maybe you had 3 hours sleep the night before, and during the day you're fatigued and you think, I'm going to go to bed really early tonight, and then I'll sleep all night and I'll get a good night's sleep. And you go to bed at 8 o'clock and you're awake at 11, and then you're awake for 5 hours. So, you think you're doing the right thing by going to sleep or going to bed early, but in the end, it actually reverses that. And continues to have a negative impact on consistent sleep. So through the program, there were a number of different things that we would get people to do. As I said before, it's understanding your sleep, and that's done by keeping a sleep diary, and participants would come in every week and we would review the sleep diary, and then we would look at those areas where maybe they could make some improvement. The other a really important thing to do is to maintain a consistent sleep schedule 7 days a week. So through the use of the sleep diary, you can determine what is a good bedtime for me, what is a good rise time for me. And then from there, you would stick to those times every single day. And that gets your brain used to those times, but it also gets your body used to those times. You know, a lot of you have probably heard of circadian rhythm, and that is that biological process that we can impose on our body. So by going to bed at the same time every night and getting up at the same time, our bodies also get used to that. So it's sort of using all of those strategies that helps your brain and your body to kind of get used to those times. So that, let's say your bedtime was set for 11 o'clock. So your brain is aware of that. You do things over the course of the evening to prepare yourself mentally to get ready for bed. But because you've imposed these schedules on your body is also starting to wind down, and all of those biological processes that contribute to good sleep are happening because you've imposed these schedules on your body. Another thing that a lot of people do is they spend a lot of time in their bedroom doing all sorts of things other than sleeping. So a lot of people will have a TV in their bedroom. They've got their computer in there. They're reading, they're crafting, they're doing all these things. So another thing that we really encourage people to do is use your bedroom only for sleeping, and only do sleeping there. And people would say, oh, I can't do that. I have to read before I go to bed. I turn the TV on and I leave it on all night. It puts me to sleep. So it's realizing that those habits, those behaviors that you do all the time that you think is actually helping you sleep are actually doing the reverse, and they're making it worse. So it's going back to use your bedroom only for sleeping. A lot of times people are spending a lot of time awake in their bed. And a lot of times if you wake up, you're worrying. Anxiety plays into that effect of keeping you awake every night. So people start to make an association with their bed and their bedroom, and they associate that environment with anxiety. So a lot of people who I would talk to about their sleep, they'd say, yeah, every time I walk past my bedroom during the day, I get this little flutter of anxiety. So it's remembering that this is happening because I've made this association with my bed and my bedroom, and I need to reverse that association. So it goes back to Dr. Pavlov and his dogs, who would ring the bell to get the dogs to salivate. So that type of behavior is called conditioning. You condition your brain to associate your bed and your bedroom with anxiety. So, it's just kind of like, that's another way to understand my sleep and my sleep behaviors and how they're actually having a negative impact. And those are all things that I, as an individual, have control over. And when I understand that, and I understand the strategies to reverse that, then I can implement that with some guidance and information and education to kind of make improvement to my sleep. Another thing people will do is they'll wake up in the night and they'll start to worry. Usually you worry. Sometimes the worry is just about being awake. But it's understanding that when I do that in my bed, this contributes to me associating my bed with anxiety. So I got to get out of this environment. I'll go worry in another room. I won't worry in my bedroom and in my bed, because that makes it worse. So when you wake up and you're awake for a few minutes, get up and get out of bed and leave that environment. So a lot of it has to do with preparing and planning, having strategies. What am I going to do when I wake up? And when people would come in and do the program with me at the clinic, then we would sort of week by week kind of go through, what did you do? How did that work? that didn't work. Okay, let's, why don't you try this instead? And we would also practice relaxation techniques and meditation techniques, so that when people did wake up in the night or even prior to going to bed in preparation for bedtime, people would practice that and get their brain and body used to that relaxation feeling. And then when they were practicing that on a regular basis, it was easy to implement in the middle of the night if they woke up or at a time when they wanted to go back to sleep. So that's kind of the basis of that kind of a program. There were lots of people who would come in, they'd be on some of those sleep medications. And I would always say, just leave things the way they are, stay on the medications, do the program, understand things, and then work with your physician or nurse practitioner if you want to start to taper off the medications. But after you've learned all the behavioral and lifestyle changes that you can make. So through over the years, I learned a lot about sleep, and I learned a lot about some of the techniques that can be really successful. The bottom line is it's lifestyle and behavioral changes that people are making, and that's hard and it takes time. So I really always encourage people to be patient, but that, you can make changes if you are able to kind of stick with some of these things. Be aware it takes time, and you do really just have to kind of play it out and see where you can get with it. Lots of people would get some improvement, but not as much as they wanted. But it was like, you know what? I'm sleeping better. I'm going to use these strategies, and occasionally I'll use this medication, or maybe some more natural supplements, and even some of the tryptophan based medications and supplements that were available as well. So I'll pass it over to Patricia, and I'm sure she's got lots of good things to say too.
Yeah, so thanks, Dr. Hudson, for sharing the information about tryptophan in pumpkin seeds. I had no idea. So that was fascinating, and I learned lots of things today as well. So I have seen a number of things throughout the pandemic with people's sleep. Often because our life has been disrupted because the stressors of the pandemic and other things. So we find people going to bed later, they're not getting sleep as easily as they might have, they're not sleeping as long as they may have, and they are sleeping more during the day in terms of napping. So that all because of the more flexible schedules with people working at home or being at home more often, we find people getting into these habits, like Lynn said, that aren't conducive to good sleep. And we know, in fact, I just saw a study yesterday, I think, that said, and this was out of Europe, that said during the pandemic, teens are actually sleeping longer, but because of the social isolation at times during the pandemic, but we found that their mood is worse because of the social isolation. So interesting how things interfere differently depending on where we're at. Certainly there's been a lot more mental health concerns in terms of anxiety and depression, worry, isolation for people that don't have close social networks, and we're more reliant on, or not close social networks, but more reliant on friends instead of family. They've been more hesitant to go out, so that's been affecting their sleep and causing those impacts on their sleep. And then also throughout the pandemic, we've heard a lot of people tell us that they feel they have less access to healthcare for their insomnia related health problems. So they haven't necessarily been getting treatment. And then once they get into these habits of napping, sleeping more, not having a regular sleep routine like Lynn had discussed, then that creates problems for people as well. When more of us are working from home, we also have the boundaries between our home life and our work life blurred. So we could be working later into the evening or getting up earlier in the morning, and that kind of impacts our sleep and goes from there. So those are the main things, kind of, if I had to summarize how the pandemic has changed things. And some of us term it chronosomnia instead of insomnia for those people that have been affected by the pandemic, and it's affecting their sleep. More generally, just a couple of other things we know, and this is often not pandemic related for sure, but as we get older, we know that we don't need as much sleep. And a lot of people find that really frustrating that they're not able to sleep their 8 hours a day on average, and that they only need 6 or 7 hours. And so it's about considering how normal aging affects us all, and how we need to adapt to that, and not expect to sleep 8 hours when our body doesn't need that as our life changes. Other things as a primary care provider that I need to think about is this sleep being influenced by other things. So is it depression or anxiety? Is it pain causing a disturbance in your sleep? Or is it sleep apnea causing these sleep problems? Because there's both physical and mental health issues that can impact our sleep. And when we think about anything that we do to help our sleep, so any interventions or management that we're going to use, we want it to increase your alertness and function. We don't want you necessarily to sleep more hours, because the number of hours doesn't matter. As I mentioned earlier, we should be sleeping, or most of us sleep less as we get older. So is it impacting your function? So making you function better, whatever we're doing to help your sleep, and increasing your alertness. And as Dr. Hudson said, some of the synthetic things in terms of medications can actually impact our sleep cycle. So it may not be as good of a sleep, even though we're sleeping longer. So that's where really, and a lot of people struggle with this because it's an easy fix, is medications may help temporarily to allow you to sleep longer, but it's not really helping your function or your alertness throughout the day. So certainly all of the things that Lynn said in terms of there's a cognitive behavioral therapy for insomnia. And then we consider sleep hygiene, restricting your sleep. So Lynn had mentioned a sleep diary. So figuring out how much on average you're sleeping every night, and then aiming for that number of hours or slightly less until we can get you sleeping for those number of hours a night, and then gradually increasing it if we need to. And then the last thing is stimulus control, in terms of, is your bedroom dark? Is there light there? Do you need kind of blackout blinds? Do you need a face mask to stimulate the darkness? Is it quiet, or is there loud sounds there? And as Lynn said, it's like Pavlovian dogs. We need to condition our brain that our bedroom is the bed and us is equivalent to sleep, not that it's going to cause anxiety or worries for us as well. So those are some of the things that I've thought of throughout the pandemic and in my general practice.
Well, this is some great conversation, great stuff I'm learning about. I see a question in the Q&A box there about aging, and if maybe all the panelists would like to comment about the aging tips and tricks that you might have for addressing sleep issues. Some of you already touched on it. So
and Jay, just because I have the ability to pop on, anyone that has any questions, please put it in the question box. And so I do like the aging question. I have had some people asking about menopausal sleep. I mean, if maybe all three of you could make comment on that. It was when I finally found out, man, you can be awake a lot during the night. So I would like all three of you maybe to make comments on that. And anyone else who wants to pop a question in now, we're going to open this for the last 10 minutes or so for the panel to answer your questions. So I'll get off again.
I can certainly speak to that. I recall one of the sleep programs that I ran a few years ago, and we had about 6 participants, and we were all women in our 50s, and that was fun. We were all suffering from the same sleep issues, and they'd all just started, and we were awakened by hot flashes and all of that. And there is no sort of like, here's what you need to do to stop this, right? So certainly if it's an issue like perimenopause, postmenopause, if hot flashes are keeping you awake, go see your primary care provider to look at what solutions you can access in order to reduce that, because that can be extremely disruptive to your sleep. And it wakes you up, and then you're awake, and then you start to worry. But a lot of the same strategies that are in the program, those sort of behavioral strategies that are good for it works for any age group, and as Patricia mentioned, you need less sleep as you age. And by keeping a sleep diary, you may find that you're getting adequate sleep, but maybe it's not like it was 20 years ago. But you have to remember is if you're only getting 5 hours now and you used to get 7, is it having a significant impact on your ability to function during the day, right? So a lot of people get a lot of stress or anxiety about, I'm only sleeping 5 hours a night, without paying attention to the fact that I guess this is all I need, right? So it's, by using those strategies of keeping a sleep diary, understanding where your sleep is impaired, and then also realizing sometimes the anxiety I have about not having enough sleep is actually just anxiety about not having enough sleep, and it's not based in anything, and I'm doing okay during the day. So that's again, just the use of some of those behavioral strategies and those cognitive strategies that are also impacting your sleep. So that's all I'll say.
I just might mention also, you could use one of the sleep apps, Sleep Cycle. Just you lie the phone beside you, face down in the bed, and the thing to look at it, is the sleep quality there. They have sleep quality measures, and one of the biggest indicators is if you're getting enough sleep or not. Is what's the sleep latency? So if you fall asleep as soon as you put your head on the pillow at the beginning of the night, it's probably not enough sleep. But if you're taking 12 or 15 or 20 minutes to fall asleep, that's about normal. And that's a pretty good proxy indicator if is it enough sleep or not.
I don't know whether I have anything else to add about aging and sleep, but it's the same things that Lynn and menopausal sleep. It's the same things that Lynn mentioned. It's not different whether you're 30 versus 70 or 50 having sleep concerns. It's all the same things, and it's trying different strategies, whether it's hygiene measures, whether it's restricting your sleep, keeping that sleep diary, as well as kind of working through, like, is it something else that's impacting your sleep in terms of another medical concern? Is there pain? Is it hot flashes, like Lynn said? Is it sleep apnea that's disrupting your sleep? Because if that's impacting your function or your sleep, and then your function and ability to be alert and concentrate during the day, then that's where the issue is. But and some people that spend 8 hours in bed when you're 70, that's not a realistic time that you're going to sleep generally, right? So it's about setting your bedtime later, picking what time you want to get up in the morning, and then putting your bedtime as such. Even though all your life you went to bed at 10 o'clock, maybe no longer is that a good time for you, because that will be impacting your sleep.
Jay, are you taking the questions and answers, or Dr. Hudson, maybe, are you seeing the questions there and maybe could answer some of those, start the conversation?
Sorry, I was looking at my other panel members.
Sorry, the other things I can add in, I see something about quality nutrition, and then I'll let Dr. Hudson jump in as well. But part of the sleep hygiene is making sure you kind of have a daily routine, that you're eating well, that you're exercising regularly. All of those other healthy habits have an impact on our sleep. So if we're not exercising or if we're not eating well, those are certainly going to impact our sleep as well. And then there was another question, sorry. Anyways, I'll jump in later. Go ahead.
There was a question about melatonin. I wonder if maybe Dr. Hudson wants to speak about that one, comparing melatonin with tryptophan, and maybe just comment on it.
Yeah, so melatonin in Canada is really not under the jurisdiction of as a drug on Health Canada. So basically, you can take as much as you like or as little as you like. I'm not a big fan of it over the long term. It does obviously helpful with resetting the circadian rhythm. So if you're trying to avoid jet lag or the effects of jet lag, then I do recommend melatonin. Of course, you would take it at the new bedtime. So if you're going to fly to England, for example, you would take melatonin 2 or 3 nights in advance in Canada at the time you want to go to bed in England. And then it helps reset the circadian rhythm a little bit faster if you want to do it that way. But melatonin over the longer term, if you take it consistently, you don't get tolerant and dependent in the traditional sense, but you do lose your endogenous ability to produce melatonin. So I don't recommend taking it every night. I think tryptophan here has the advantage because tryptophan allows it to bifurcate and have it as serotonin during highlight hours, and using a sleep mask, or what we were discussing before, what Patricia was mentioning with the environmental cues, the blackout curtains and that, which make it melatonin as soon as your eyes see light, then it's back to being serotonin. So it kind of, you're plugging it at the front end right at the back end. The other thing to note is that the American Army did extensive research on trying to get people to reset their circadian rhythm as quickly as possible when they're flying large amounts of soldiers into Afghanistan and Iraq. And what they did is they developed the anti-jet lag diet. And so through the University of Chicago. So if you're interested in looking at that, that would be interesting. It's also helpful for sleep in general. So, but it's basically feast, famine, feast. And if you're flying our army over at a plane, famine is salad. So you eat salad on the plane, but you eat feast, and it should be a mixture of carbohydrates and high quality protein. And then on the other side, high quality protein and carbohydrates. And feast, famine is just avoiding those things and eating vegetables, as appealing as that sounds. So you can do all that. I think it's important to remember what I said about the tryptophan paradox. So if you eat a high protein meal, so if you have a barbecue at night, a lot of steak, not a lot of carbohydrates, you're gonna have a lot of circulating tryptophan, but also a lot of circulating other competing amino acids. So if you have a big protein meal at night, you're not going to sleep as well as you would otherwise. If you have a lot of carbohydrates at night, especially complex carbohydrates at night, you're going to sleep better than if you have protein at night. So just try and make those shifts from, people typically have carbohydrates in the morning and proteins at night. If you're having a real problem, maybe switch the proteins over for breakfast and have the carbohydrates at night, just to kind of give yourself every advantage that you can.
I would say also that if someone is concerned or has questions about, how different types of nutrition affect their sleep, that's another way you can start to track things. If you think, am I eating too many carbs in the evening or too much protein at dinner? If I eat a late dinner, do I sleep worse if I eat an earlier dinner? Like, all of those things are self-directed, right? So you can look up research and see, what's recommended. But really, if you suspect something about yourself individually, start tracking those things that you may have questions about and see, does it have an impact on my sleep? I also have some recommendations for some free resources that people can go to learn more about some of those behavioral changes or modifications that you can make in the CBT for insomnia. And if anybody doesn't know what CBT stands for, it's cognitive behavioral therapy, which has been an evidence-based type of therapy used for therapeutic approaches to all sorts of mental health issues. So it's been adapted into treatment for insomnia, and that's what CBT stands for. But I had provided Jay with with a slide with those self-help resources. Yeah. So I'm not a techie, so I don't know how he can provide that to the participants, but oh, there it is. Perfect. Okay. So the CBT -I for insomnia, that's an app you can put on your phone that encompasses all of the strategies that I worked with in the program that I ran. Sink into Sleep, again, that's a book, same thing. A lot of the information on those strategies are there. Mind Beacon is a Canadian online mental health service. So you would go on there, you would register, provide some information to them, and then you're linked individually with a therapist. And if you want to say, all I want to do is access the information for sleep, then they can set you up with that. But it does take a few days and a little bit of back and forth email with a therapist that they would link you with. And then there are the other thing there is just some apps that have free guided relaxation and meditation resources for people, which are great things to have under your belt if you're awake in the night and you're anxious or just in preparation for sleep. So all very good resources.
Yeah, I support Lynn. It's more about an individual journey with sleep. And if you're really struggling and you've tried some of those resources, then reach out to your primary care provider and they can help you help coach you through kind of the exploration as to what may or may not work for you. But the basis of sleep, whether it's from a psychiatrist perspective or a primary care or social worker perspective, it's hard work at the patient level, and it takes a lot of time and resources, and there's no magic solution for everybody. But medications are generally not the answer. They'll help for a night or two, but long term, they're not going to improve your sleep. In fact, they can make it worse.
I think we have time for one more question from the audience. There's one that I see, it's intrigued me too. Cannabis for sleep. Would the panelists like to comment on cannabis in particular?
I've heard lots of info, but I'm interested to hear Dr. Hudson's perspective on that.
I was hoping to avoid comment. I'm not a big cannabis fan. I'm disappointed that it's legal, to be honest with you. It's had a huge impact on youth and mental health. I'm just not there for that. I mean, there are many options. I guess one of the things I could think of, if you take tryptophan, and I mean even synthetic tryptophan, where you before an examination, you actually increase your performance on the examination. Whereas with cannabis, you would degrade your performance. So I know cannabis is a huge issue right now. Many people endorse it. Many doctors endorse it. It's prescribed all the time. I'm just not one of the people that's enthusiastic about it, unfortunately.
Anecdotally, I think there is a minimal amount of research evidence that supports cannabis with sleep, but anecdotally, I have some patients, but they're generally people that don't want to put in the effort to fix the other things. And unfortunately, they still become an impact on their sleep. So it works for a while, but then down the road, in my experience, the patients haven't had success long-term with it.
And I would just say it is one more thing people can experiment with. But my recommendation always is don't go to a cannabis store and just buy it off the shelf. Do your research, go to your primary care provider, or go to, I think it's the Online Canada Cannabis. I'm sorry, I don't have the name of it, but it's where you can go on and have an online appointment with a with a physician or nurse practitioner who will prescribe it. But going to a cannabis store and just buying whatever they're selling, I would do it through a medical professional first. So, but anecdotally, again, I agree with Patricia. I've seen it work, but I've seen it not. And it certainly in adolescence, I would not recommend it.
We're drawing to a close. This has been fascinating. Dr. Hudson, there was one question about herbal teas. Would you touch that one? And
yeah, there's not a lot of evidence, but anything that helps you initiate a routine around sleep can be helpful. So, having a sleepy time tea may not really induce anything for your brain, but just having something that kind of gets you ready for bed. The German scientists call them Zeitkeepers, so time givers, and that's really important. So if you have a bedtime routine and herbal tea is part of that, it would help. Yeah.
oh, excellent. Okay, well, I'm sorry that I have to wrap this up. Again, it's become so topical with the pandemic. I think, people have been so focused, but this has been a fascinating conversation. And we know the lack of sleep, how it affects our well-being in general. And I know who I am when I've had a good night's sleep and what I'm like when I haven't. And you don't want that other person. So our challenge now is to digest all this great information and try to get better sleep for ourselves and help others with all of the information. This has been fabulous. And it is just what Gateway is all about, bringing relevant health information to our rural residents. So better sleep, so important. The amount of information you've brought has been fantastic. So thank you so much, Dr. Hudson, for creating a conversation surrounding this topic, and to the panelists for all your insights. Thank you so much. A huge thank you to our sponsors for the continued support. Without you, the lecture series would not be possible. CIBC, Private Wealth Management, DeJager Town Square IDA Pharmacy, and the town of Goderich, as well as CERH of Goderich. Gateway Center of Excellence in Rural Health is a not-for-profit organization with charitable status, and we greatly appreciate and welcome the support we receive. Lastly, thank you again for all of you who have attended today. Stay tuned for our new edition of our lecture series on March the 1st. And feel free to pass the information along to your networks to expand and reach this lecture series to all, with the aim to promote the knowledge economy, reduce social isolation, and support Gateway's mission, improving the health and quality of life of rural residents. So thank you so much for spending this hour. It's been fabulous. Thank you.
Thank you.
Thank you.